Hi, good evening. Thank you for joining us. Thank you, David. I feel very privileged and honored to not only speak tonight, to have all the panelists here on the board with me to talk through diode lasers and how to improve patient care. I'm going to run through a couple of slides, a high-level overview of Wednesday night for those of you who are unable to attend. And with that, I want to leave lots of room for questions. We had a lot on Wednesday night that we were unable to get to, so we want to start by that, as well as incorporating live questions tonight. So with that, I'm going to go ahead and get started. I'm going to quickly read this disclosure. The content, recommendations, views, and opinions expressed in this course today are solely those of the speakers. So a few things, I tried to pick out some of the best. There was a lot to choose from. The benefits of diode lasers. Helps you run on time because the patients are healthier. So when you get them in your chair, it's a lot less work, a lot less strain on the patient and the hygienist. Sets the practice apart by being health focused. Patients understand that you really care about their whole health. The technology increases efficiency and attracts patients because they are looking for that technology and bettering their health. Increased standard of care all the way around. Of course, I mentioned the other night, it's safe for anyone, including children, pregnant or nursing mothers, and medically compromised. Reduction of bacteremia, periodontal pathogens, and cross-contamination, which cultivates a healthy microbiome. It accelerates healing, more overall comfort, and less need for analgesics and opioids. And of course, those are just a few. Safety and protocols that I went over. Again, I just want to highlight some of the main things. Always check your state, province, professional board. Even though there are other resources out there, that's going to give you the best information and help you understand your scope of practice. I always recommend taking a laser certification course, even if your dental board or your scope of practice does not mandate it. It helps you learn all the different things about the laser and how to use them. A laser safety officer, you want to appoint someone in the practice for that, and of course take the required training to become the laser safety officer. Always wearing the appropriate safety glasses that coordinate with the laser that you have in your practice, wearing that appropriate mask, which right now is class 3, level 3.1 microns. Always using the high volume evacuation system, and of course reading the owner's manual for all the other guidelines that you'll need to use the diode laser in your practice. And I did this return on investment from the prices that in my practice and things we do, and I tried to make it very simple and something very achievable in the practice. So quickly, I'm just going to go over this, the codes, and David will talk more about that at the end. Dr. Lau and Teresa Duncan will be doing a webinar on April 4th in regards to codes and information in charging out the laser. But quickly, what I did was most widely used is the 4999, and that is an unspecified periodontal procedure report. You also can just increase the cost of whatever procedure you're doing. So if you're doing a periotherapy, you could pad that cost so that you could get on a return on investment there. You are providing an adjunctive service that you can't get in any other technology out there. So I just wrote down a range. In my practice, it's $50 for LBR. So if we did that on everyone, which we highly recommend decontaminating pockets on all of our patients, if we had 40 patients in a week, this is just with one hygienist, and we have 50% acceptance rate, you can see that would add up to $48,000 yearly. I did the same thing with periodontal therapy at $90 a quad, and that I only did 5 patients a week, which I believe is very attainable. It's 1 patient a day, enrolling them in periotherapy, which equates to about $86,400 yearly. And then of course the aphthous ulcer or herpetic lesion. As you introduce this technology and you let people know that this is something that you've incorporated in your practice, you likely will see much higher patients with aphthous ulcers and herpetic lesions. Some patients just don't talk about it because they don't know that you're able to help relieve that pain and decrease that duration. So I did 5 a month. And so with that, I came up with $138,000 additional revenue to the hygiene department. And that's one hygienist. So think about that. If you have more than one hygienist, you'll double that, triple that, or, in half if you have a part-time hygienist. So I just wanted to give the highlights of Wednesday night. And now I would like to pass that back to David, and we can open the floor for any questions that you have for the panelists.
Thank you very much, Paula. Yes, in fact, to your point from Wednesday, we had many more questions that we could get to, even though we tried to think about it in terms of categories, but I do have some that I think will get us started this evening, and I'm seeing 8, 10, 12 already new ones, so I think we'll be pretty busy here for the remainder of the hour. With that being said, I've sort of broken them into some segments here, and I think I've separated them out here just a little bit. Valerie, you have a lot of extensive experience in not only dental hygiene practice, also billing and coding, et cetera. What is your post-operative laser instruction or post-treatment laser instruction when using a diode for gingivitis and scaling and root planing, et cetera?
Great, David. Thank you. So, for gingivitis and scaling and root planing, it's really, oral hygiene as usual with the regard of OHI. So we still want our patients using, soft bristle brushing, their antimicrobial or antibacterial rinses that are preferably alcohol-free. In addition, with laser treatment, the things that we want to instruct our patients to really stay away from is, no crunchy foods for 2 weeks, not to be taking toothpicks or anything down into the sulcus. We want to allow that area to heal. And so that would be the only thing that would be different when we institute laser therapy into the practice. Just a great, another best practice that we do for patients in our office is we apply a vitamin E oil after we do laser treatment. And so in addition to those types of post-op instructions, we'll instruct them not to eat or drink for 30 minutes while the vitamin E oil is setting in as well.
Excellent. Thank you, Valerie. And Christine, I just want to make sure that we don't leave you out here. You've got such great experience. I have a couple, I think, that are more directed at you. This particular question is about tips. When might you initiated versus non-initiated tips for treatment? Can you add a little bit of color to that, please?
Yeah, yes, I can. First off, please check with your laws and make sure that you're able to use a laser in general. Initiated tips are going to be used in your laser-assisted periodontal therapy or your LAPT. Some states allow that for the hygienist, some states do not. So you may want to look into that. Everything else that we do in the hygiene chair, from aphthous ulcers to herpetic lesions to LBR, are going to be used with a non-initiated tip. The initiated tip is just a tip that has been darkened and runs and becomes more attracted to the chromophores in the tissues. So it's going to be a little more, I hate to use the word aggressive, but it's going to be a little more aggressive in what you're doing than the non-initiated tip.
Excellent. Thank you for that. And Paula, one for you. I've got a couple coming in for Dr. Lau as well. But Paula, when are you substituting a laser? I'm reading the question verbatim. When are you substituting a laser instead of instruments during regular prophy, or is it a laser used as an adjunct to manual instruments as well?
Great question, David. I'm actually not substituting the laser for anything. I use an antimicrobial rinse prior to the appointment. I use the laser to decontaminate the pocket prior to, let's say, a prophy or a gingivitis, or actually any of those procedures. And then I do the procedure as normal. So if it would be a prophy, I would then use my Cavitron, my hand scalers, and polish, and then so on for each other treatment. So it is an adjunct to my hygiene visit.
Perfect, thank you. And Dr. Lau, there's several here for you, and I don't want to get in the way of the panel having a discussion with one another, but I think I'd get to question each one of you, and then I'll ask the questions of the entire panel, and then I think you can answer as you'd like to. But Doctor, as you know, there was recently an indication awarded for laser bacterial reduction, or LBR. And the question from Diane, if I'm reading her name correctly, is with LBR treatment, doctor, how long for the treatment and how much bacterial flora is reduced?
Well, the first one, no one really knows about time, although most of us use consideration for 10 seconds, and that is circumferentially or completely around the tooth. The slower you go, the more active it is. There is a myth that you need to go down to the bottom of the sulcus. If you know diodes, they're really looking for anything that's a chromophore, black or brown, into the tissue. And so therefore, all you have to do is put it 1 millimeter into the sulcus and then fire the laser at generally around 0.5 watts, uninitiated, as was taught, with continuous. We don't really know about the effects of the antimicrobial properties of LBR. We realize that they are effective, especially around such organisms as Porphyromonas gingivalis, because it's already pigmented. So anything that takes in heme and is colored, then naturally there's going to be more of an attractant. But for the studies, as far as the effectiveness goes, we at this point, we just really don't know. That's probably why laser-assisted periodontal therapy with initiated tips and creating a thermal reaction, if one really wanted to try to get approaching sterilizing a pocket, that would probably be more appropriate, although LBR is such more easier to do and more patient acceptance.
Thank you, Dr. Lau, very much. So these are some live questions, if you want to consider that, versus the ones maybe we saw on Wednesday. And I think it'd be nice to get to those live questions. It's the group we're talking to this evening. And this is from Sandy. It's not directed at any one of you, but rather at the panel. Can lasers help reduce viral load?
Dr. Lau, I think that probably would be a great question for you.
There are studies that do demonstrate a decrease in viral load. Please appreciate, unfortunately, a laser is not a laser is not a laser. So it depends really on what laser you're talking about. As I mentioned, viral loading is very susceptible to heat. So therefore, we're talking about the right wavelength here when we talk about diode. And essentially, the more we do our laser-assisted periodontal therapy, in other words, initiated tip, the more we are going to see a thermal reaction and the less viral load. I think when all of this is over, what we're going to find is not just about the particular device you're using, but the entire protocol from the time the patient walks in the door until they leave. And if you go on the ada.org, you're already seeing, and I would highly recommend that even though it's for emergent patients now, it's my feeling that much of this is going to translate once the doors go back open. And so if you look at that, what I really want to encourage is no matter what you do, the pre-rinse is going to be mandatory from now on. It will be mandatory. The two pre-rinses that are out there that seem to get the most traction is going to be anything that is iodine related and anything that is hydrogen peroxide related. Those are going to be the two in some format. I could possibly throw bleach in there, but at this point, it's iodine. So pre-rinse, what was 30 seconds, I think it's going to end up being 60 seconds before this is over. So if you literally take care of the mouth before you use the device, then probably you've got a better chance that there's not going to be any viral contamination, and no matter what we do.
Excellent. Thank you, Dr. Lau. Any of the other panelists care to add to that? Otherwise, we'll move on.
We can move on. I think we all agree with that.
Okay, I know I do, and I'm not a clinician. So from that standpoint, this came up Wednesday, and while we touched on it briefly, panelists, there obviously is a lot of interest in diodes for treatment of TMD. And so the question is asking the panel, how would you use a diode or a laser is actually the generic question here to treat TMD. I know that it's done quite a bit with diodes, and perhaps any or all of you could add a little bit of color to that.
Well, I could start because TMD is a dental condition from the standpoint, and again, you'd have to check your state laws on whether a dental hygienist could manage that condition. I know it was mentioned before, and it was on target. I think it was Christine. When you look in your state laws, many times they'll say you can use a laser for every delegable duty for a dental hygienist. And so it's sort of a little, you think about it that way, but that's the first thing I would do. And so therefore with TMD is really, we consider that to be deep pain therapy. Now let me caution you, unless you have a laser that has a particular handpiece for managing that, you're flying by the seat of your pants if you use it any other way. When you get into the laser physics business, you start talking about spot size. And so everything depends upon how much energy is being transmitted from the source, from the laser. So you can imagine, is the diameter of the energy coming out. It is the distance between the energy and the target, which is the TMD. And then lastly, it's about how quickly you move the laser. So if I take the laser and I'm out here versus here, and if I'm doing this versus doing this, and my spot size is here versus here, you can see. So I always recommend, if you're going to use your laser for TMD therapy, you need to find a diode laser that essentially has the right handpiece and also has the right instructions. So you will ensure that you are doing this that's going to be effective. It is effective, by the way. It's very effective. And sometimes it can happen just with one setting. So there is one diode out there that I can suggest to you. It runs with this particular handpiece at 4 watts at 300 seconds. But imagine 1200 joules. So this is really not biostimulation. This is really bioinhibition by infrared. And by the way, that's what FDA has cleared these lasers, these diode lasers for, is for the infrared deep pain therapy.
Excellent. Paula, Valerie, Christine, anything to add to that question?
Yeah, I just wanted to say, David, you know, one of the things that I love about the Epic H is the apparatus that it has it is, you know, it has that precise distance that Dr. Lau was talking about, and really makes it easy for the clinicians to use it in the treatment of reducing that inflammation for the TMD. So you know, I can't use it in my practice based on my practice act, but my doctor is able to use that, and it's a great therapy for our patients.
Great. Christine, I'd like to direct this one at you. Obviously, you have a wealth of experience as well. The question is from Ben. Why do you use laser therapy prior to Cavitron and hand instrumentation versus after the calculus and plaque has been removed from the tooth surface?
Great question. I do an LBR before anything I do on a patient. In my practice, it's just our protocol. And what we're really aiming for is to reduce the bacterial load as much as humanly possible before we go in and start having that communication between the mouth and the body, meaning once we start the bleeding, we're going to get the bacteria into the bloodstream and things like that. So we want to reduce it as much as humanly possible. And that's really the reason to use it. Even before doing a scaling and root planing, we'll do an LBR, then the scaling and root planing, and then the LAPT. So we're really using it as a decrease in the bioburden, you know, for each patient.
Excellent, Christina. And I think this question is a nice sort of adjunct. It came from another of our members in the audience. Her name is Jenny. Are there any contraindications in using a pre-rinse and then going directly to LBR?
The only thing that I would caution you on, and it may be the lowest level caution possible, is making sure that your pre-rinse doesn't have alcohol in it. I would just be careful with that. But the pre-rinses that we use in our practices generally don't have a high alcohol content or have a zero, alcohol content. So that's the only thing I would caution you on. Is it a prudent caution? Who knows? Just be careful. You just want to make sure.
Fair enough. And there's several questions about initiated and non-initiated tips. And I know we spent a few minutes talking about it. This particular question probably covers 4 or 5 that I'm looking at. And how during treatment would you, and this is to any of you, how would you avoid the tip becoming initiated during treatment?
Well, I'll start. I don't think that you can avoid it. If you hit that tissue, that diseased tissue, in my experience, it's going to initiate. Now, what you do then is up to your scope of practice. You may be able to wipe it and cleave it, or you may have to, if you're using a disposable tip, you may have to get a whole nother tip. But typically, if that tissue is diseased and you get in that area, it's going to automatically initiate. Anyone want to add anything to that?
No, I was gonna say the same thing, Paula. I mean, even if our intentions aren't always to pre-initiate, when we get into that disease sulcus and is attracted to those chromophores and the hemoglobin and the color there, so it's gonna initiate at times, and that's where you just use your clinical cap, and that's where the training that comes into place, and to just take it out, cleave it, get a new tip. Whatever, again, your practice out, get that granulation tissue out as much as possible, but within your scope of practice.
If you use at most 0.5 watts and you're only 1 millimeter in the sulcus, unless your area is highly inflamed, it shouldn't initiate as much, or even if it begins, always have a wet 2x2, because what happens is if you allow it to initiate and you don't do anything right then it literally becomes centered into the glass itself, and it's very hard to remove the initiation. The problem with it being initiated is not just about practice act. The problem with it, if it initiates, then all the energy is going to go into the initiation and none of it is going to go into the bacteria. So one of the real issues here is initiated tip, because it becomes the chromophore. So then all those porphyromonas, gingivitis, anything that's pigmented in the bottom of the pocket, the only thing that could happen is a little bit of heat. So yes, I always have a dental hygienist having a wet 2x2, and anytime it even smells like it's going to initiate, wipe it off.
Thank you, doctor. And speaking of pockets and tissue, there's a small group of questions sort of talking about those things. They're fairly general, so I wouldn't direct them at any of you, but perhaps you can take a turn or two here. So this is from Irina, and if the pockets are 2 and 3, is laser effective, or why would you use a laser on these patients?
I can answer that, especially with LBR. When we wait for disease, destruction's already happened. So that's how I look at it. That's why we LBR all of our patients. So if we're waiting for the bleeding, we're waiting for the inflammation, we're waiting for the deeper pocketing, disease is already there. If we can laser these areas, get the body cells to start turning over and start the body healing itself and eliminate the bacteria, we've actually very likely caught it at a subclinical disease. So the destruction hasn't happened yet. So that's why we use LBR in our practice before, just on everybody.
And if I can add to that, one of my main purposes for using it is that pocket decontamination to reduce the bacteremia and cross-contamination. So I'm trying to reduce that as much as possible before I start using my hand scalers.
Excellent. You know, Paula, this came up on Wednesday, and I think it's important. I know that you and many of the panelists were involved in developing a hygiene laser, if you will, or epic hygiene for hygienists by hygienists. Are some of the settings, and there's some questions about settings, and maybe you could talk about the interface there for just a moment, because I know that's your experience. I'll queue up some more questions, but quite a bit of questions about settings. And I know, you know, with other lasers, you know, settings are going to vary a little bit from laser to laser, but in your experience, maybe with epic hygiene, you know, are there some advantages to that? And, you know, would you want to talk about that opportunity?
Yeah, you know, we talked about the ease of use, the great ergonomics with it. It's a very intuitive machine, and that's, you know, why we developed it like that, because we know that, you know, many times these lasers get into practices and they can be confusing, and if you don't know exactly how to use it or the right training, or you forget, then it's left unused. So that's the one thing I love about the Epic Hygiene is there's preset buttons for pocket therapy, perio-debridement, the aphthous ulcers and herpetic lesions, and even hemostasis. So those are definitely guidelines, but they're pretty spot on. So if you're beginning, you could feel comfortable, you know, hitting those preset buttons and moving forward with treatment. Now, as you get more experienced, you might change those settings, you know, just a little bit up or down. And of course, you always want to be careful, you know, with the patient themselves, the tissue, the color of their tissue initially, and then the more diseased it is, you know, you might be lowering those presets. So, but that's what's great about it is the ease of use, and it's, you know, very
user friendly.
Can I say that enough?
Thank you. Well, maybe kind of dip our toe back into some more clinical things as opposed to settings. You know, that's a difficult question for any of our panelists because there's so many choices out there. So, you know, setting one on one unit versus setting two on another, I think is important to, you know, have a good understanding of the equipment that you use. Would that be a fair statement to all of you?
Yes, and I think too, you know, just based on different types of lasers, but then what was getting back to what we were talking about earlier is, you know, the patient's tissue. So obviously the more diseased the tissue is, and what we talked about where we could, at some point, sometimes we see that self-initiation. Well, that's when we know, you know, we need to take it out, we need to cleave it, clean it with a wet 2x2 and bump those settings down. So those settings are there for us to give us that baseline. But again, every patient's different, their tissue, how diseased they are, how, you know, how fibrotic it is, that's all going to also come into play on whether we're going to bump it up or bump it down a little bit to meet the needs for our patient. Would you all agree on that?
Yep, absolutely.
Okay, perfect. There are question after question after question about the rinses, and I think we don't want to go necessarily just to a rinse discussion, but what they are suggesting is perhaps the panelists could recommend the name of the rinses that they're most comfortable with or they're using most often, just to give some of the members of the audience an idea about some of the materials you're using.
Yeah, so, well, Chris and I are big, we love OraCare. You know, we're big advocates of that. I know Dr. Lau has his favorite. Dr. Lau?
Yes, I believe that I think we're getting away from periodontal diseases being totally infectious. I've never believed that in the beginning, and moving more towards chronic inflammatory. So in my mind, whatever you're going to use should not only be antimicrobial, but also anti-inflammatory. And so I look for something that has antioxidants in it. And just personally, myself and about 4,000 or 5,000 other practices, we use Perio Sciences, we use AO Preventage Gel.
Thank you, Dr. Lau. So I think there's probably a lot of choices out there, and I'm glad you guys have recommended, you what you are comfortable with and perhaps what you're using. In terms of rinses and other things that might be different from a normal setup and hygiene practice, there's some questions about protection. Paula, on the Wednesday presentation, you did spend a fair amount of time on eyewear and those types of things. You might want to go back over that there's several questions about what type of protection is necessary to operate a laser safely, if you want to spend another minute talking about that. And then a couple of questions are a little bit easier, but I think they're part of it. Can you use loops while you're using a laser? So maybe just focus on, safety for a moment or two, and the panel can weigh in on that as well.
Okay. Yeah. The best thing, like I said, is to take the certification course, because they're going to make sure that you absolutely get all of the guidelines that you're going to need for the safety of the laser, the safety of the patient, and the safety of yourself. Just to reiterate, there are particular eyewears for particular waves, and it will say that, in the manual, and it will say it on the side of the safety glasses. There's a lot of different, I talked about having to be a certain area away from the patient. I talked about keeping the oxygen tank out of the room. There were so many things that I discussed. But the best thing, like I said, is going to be that certification course and the owner manual of the diode laser that you're using, because both of those, between the two of those, it will have every safety precaution that you're going to need. And of course, always using that high evacuation system in your room is also very important. Does anyone else have anything that they want to add to that? Or do you want me to be a little more specific, David?
No, I think just looking at the questions, they're quite general. And I think that's good. Christine or Valerie, anything to add that's different to that in terms of, some of the safety choices or instruction that you give?
Sure, just the loops. I think part of the question was the loops. Right. And so, yeah, there are inserts that you can get in your loops, and some other, again, manufacturers that you want to match with your specific wavelength for your laser, so that you can definitely look into that. There are manufacturers out there to make the inserts or safety, so you can still use your loops.
Thank you, Valerie.
Sure.
And with the loops, I just, because I use the laser so much, you can actually have the wavelength built into your loop. So I have all the wavelengths, current wavelengths, I should say, to my loops. So they can do that for you. It does change the color very slightly, but it's nothing that you'll notice, over any period of time. So you can do that if that's something you want to invest in.
Terrific, Christine. And Christine, while we have you sort of on the big screen here, there's a couple of questions I think are really a very good fit for some of your experience, particularly around coaching. And some of it's just the talk tracks or communication strategies with patients about accepting treatment, number one, or paying out of pocket for treatment. So they're similar questions, but they're a little bit different. I'll start off with something a little bit more general. It comes from an anonymous attendee, so I can't tell you, unfortunately, who asked it. But is it difficult in your experience to get patients to agree to out-of-pocket procedures such as the laser? What is your recommendation on how to get a patient to accept out-of-pocket costs for those?
So Paul and I believe the same thing, because we've taught together for a very long time. One of them is getting the patient to own their own disease. That is so critical, because they think they come to you and you do your thing and they go home, and it's their disease. So that's one of the big obstacles to get over is, you have this disease, okay? This is what we know now. Studies have shown this. And then we just start hitting the barriers that would come up in a conversation, because every time a patient has to ask a question, it raises a wall of, oh, no, I don't want to do that. So it's, here's what you have, here's what we can do today. It will take this long, you'll be very comfortable, it costs this much, your insurance is not going to help you with that. What questions can I answer for you? And that's really how I present everything from laser to fluoride to sealants to any adjunctive service that we're gonna give in our operatory.
And I just want to add to the beginning of that, because Chris is right, them owning their disease. And the other thing and that's part of it, is connecting it. So when you go through, why is your patient in your chair? What's most important to them about their oral health? And then when you get to that point where they're diseased, or you want to use the laser or any instrumentation or technique or technology, you know, it's always going back to what you see in their mouth and what's going to happen if you don't proceed with it, and then what's going to happen if you do, so the benefits they're going to get from doing it. So making sure that you're connecting all of those dots so that they, you know why they were there in the first place and what you can do to help them overcome that disease or whatever path they're headed down.
Perfect. Well, I think that's great, and you know, quite a few questions from the audience just about LBR and how to talk to patients about that. It seems that this is coming from Rocio Flores, so thank you, Rocio, for the question. That she works in pedo practices, and so LBR is a little bit harder to discuss. And with that age of patients, do you change the talk track, generally speaking, to patients depending on the age? Obviously, with the younger patient, there would be a parent involved, but you know, does your communication factually change at all, or how do you approach younger patients versus adult patients?
Does anybody want to grab it, or?
Well, I don't see a rationale for LBR on deciduous teeth unless a patient is demonstrating some type of pre-puberty periodontitis, gingivitis kind of thing. So, but with adult teeth, then I think then it would be very appropriate to consider laser bacteria reduction, especially in a group that is called the orthodontic patient.
That's what I'm
Glorious for inflammation. It's amazing to me, if you look at the average teen that is in ortho, and I'm talking not about trays, I'm talking about primarily more with bands, braces. It's amazing they have any teeth left by the time they finish their ortho. So that's a whole different animal, and one I think that but I think some of us ignore that type of gingivitis. And let me just give you a thought. Some of us are starting to believe that longstanding gingivitis, even though it's over, it's still there. You still have hyperactive neutrophils, lymphocytes. So you can't just use clinical signs and symptoms for this. You have to look beyond that, because many of us believe it is an antigen-antibody reaction, and that's where the chronic inflammation goes. So for ortho patients, to me, it is a mandate.
Thank you,
I'm glad
Dr.
you added
Lau.
that, Dr. Lau, because I know that we were all like thinking that Val might have something to add. She's went through 3 teenage boys, and Chris has gone through a couple herself. So I have girls; they're precious.
Well, I was going to say, Dr. Lau, that you have a couple of Invisalign faculty members on the panel tonight, so they probably know more about some of the difference between removables and fixed than would ordinarily be the case. Having said that, I know that, and I'll make a slight announcement here as we're in the last 20 minutes, at about 15 minutes till, regardless of where you are in the world and your clock, we're going to go to some live questions from the attendees, and my colleague Nathan will be helping to moderate that. So from the Q&A panel questions, maybe just 1 or 2 more. You know, Valerie, I'd like to direct this one at you, if I may, because there are a few questions that are very much general in nature about how do I get started? So there's some hygienists in the audience that are wondering about certification and training, et cetera. You know, what might be, Valerie, a pathway into whatever state they're in? You know, how do they sort of get started, talk to their dentist about it, and what do they need to get to you know, a treatment type of position?
Well, that's a great question, and that is such an exciting question, right? So that's why we're here. So, you know, being a laser hygienist since 2003 and having that a part of my armamentarium, it excites me that these hygienists want to get this started right away. So the first thing we need to do is you need to check your state practice act, whether it's if you're in Canada, your Providence, or, you know, here in the US. Every state's going to be a little bit different based on the hours of your certification. There's some states that say you can do half of it, you know, online, the other half in person. Some are 8 hours, some are 12 hours. So you need to know state by state where you are in your area and what those regulations are. So do that first, and then find, there's great resources out there, trainers out there that are certifying. You can go through the American Academy of Laser Dentistry, and they'll be a great resource for you. And there's some other, Christine that's on today does certifications, and there's quite a few handful of hygienists in our network that train and can certify. I know BioLace, get with your local representative, especially because they're in your area and they know they know your state laws in your area. They're very familiar with what's going on in your area. They can help you get started as well.
Yes, that's great. And Christine, I know you do this for a living, so certainly a very direct plug if people want to look up, where you are and where you're training. But having said that, anything to add to, Valerie's, I think, very comprehensive takeaway. But if I wanted to get started as a hygienist, how would you I'm already a hygienist, but I want to get started with lasers. How would you suggest I get about that?
I believe what Valerie said was perfect. Okay. The ALD has a great resource where they almost do like a pre-laser course. Is that recorded, Dr. Lau? If they join ALD, can they get a hold of that?
Yes, there actually is an introductory course without them joining it.
Oh.
Excellent for them. I think it's about 50 minutes at the most, and it's a CEU. But ALD does have a great introductory course. We just created a new revision here in the last 12 months. Terrific.
Well, thank you all for taking a cut at that. I agree with Valerie.
Because it's close to my heart.
Sure.
A course, even if it passes certification in your state, that is not hands-on, that's only online, in my mind, is not acceptable. Not sure what the other panelists think about it, but there's manufacturers that will give you, online courses all day. But you need hands-on training. As Paula suggested to you, this is not for medical laser. I mean, this is not something you buy from eBay. So just a strong caution, please don't just take an online course, go in, turn the laser on, and start going around the sulcus.
Excellent, thank you. With that being said, as we're in the last 12 minutes or so of our time together, I have a colleague, Nathan Cardenas, who's helping me behind the scenes with the panel and managing the event this evening. And Nathan is going to take the controls, so to speak, here for a few minutes and engage with some of our attendees via live question and answer. Nathan, take it away.
Thank you, David, and thank you, panelists. So for this live question portion, you're going to go down to the bottom of the toolbar on Zoom and click raise your hand. If you'd like to answer a question live, raise your hand and I'll go down in order, message you, and I'll give you the mic. So first we have a question from Mary Beth Newport. Mary,
yes.
Can you hear us? Great.
Yes, can you hear me?
Yes.
Perfect.
Yeah.
Perfect. Okay. So I've been a hygienist for many years. I practice in Southern California. Currently, I've been off for 3 weeks. I have no idea when we're going back here. And there has been a financial concern with the LBR by some of my patients. And now I'm curious with when we return, how should we word this verbiage and even consider maybe lowering the fee? Or if there's really an extreme concern financially, could we just limit it to maybe a quadrant or two to the patient? Do you ever do it that way with financial concerns?
Well, can I ask first how much you're charging, just out of curiosity, to just get a price point? Or is that something you're comfortable sharing?
Sure. It's usually, sometimes they modify it, but between 35 and 50 for the full mouth.
Okay. Yeah, I think that's a great price point. And again, I think it goes back, I mean, in my opinion, definitely finances can be a concern, but I feel like finances usually outweigh moving forward when patients don't completely understand why you're doing it and how it's going to benefit them. And again, the consequences that may be left behind if you don't move forward with it. I think all we can do, the best we can do, is explaining how it can affect their health and their whole body. And then, of course, it's always up to them. But as for doing LBR in one area, I mean, you're going to be, if I understood right, you're going to be doing a treatment, unless you're doing a quadrant, a therapy, periotherapy or something, you're going to be treating the whole mouth. So I would highly recommend doing the LBR throughout the mouth.
Yes.
Anybody have anything to add?
Yeah, well, generally I was saying like for a prophy or perio maintenance, I prefer to use it everywhere. But again, now that I'm thinking, patients might say, well, can you just use it where I really, really need it? If that's a concern. And, that's what I just wonder if we're going to be facing that issue.
Right. Anyone have anything to add, Chris, Valerie?
No, it's going to be tough. Like this is unprecedented, the COVID, right? So coming back and being off work for this long, it is what it is. And this is a health service. It's not a cosmetic service in any way. So really, I think just like Paula said in the beginning, speaking to what's important to them, letting them know why you're doing the procedure that you're doing. And you can do anything you want with the price. So let's put that out there too. Between you and your office, you can do whatever you want. However, it's usually, and I'm going to say this as a generalization, not for this particular situation, but it's usually about the value of the service, not about the money. So when Paula said they're not understanding why it's so needed, is usually they go to money because it's the easy thing to go to. Yeah, I don't want to do that. It's too expensive. So it's about the value of what you're providing for them. And I think speaking to that and letting them make the decision. Ultimately, it is their decision whether they want to do it or not do it.
Thank you.
Okay,
Thank
yeah,
you. That was
hopefully
very
that helps.
helpful.
Thank you, Mary Beth.
Thank you, Christine, and thank you, Mary Beth, for the question. I do see that we have a Hope Griffith here. I'm going to ask you to talk right now. Please unmute your microphone. And you're live.
Hi. Can you hear me?
Unfortunately, your internet quality is quite poor. If you put the question in chat, I'll be able to read it for you. Apologies.
Perfect. My name's Hope Griffith. I am from Kentucky.
I'm sorry, Hope, we had to remove your audio. We were unable to hear you. I do have a question live from Scarlett Arakilian. How do you charge the TMD patients?
Do you mind if I
Well,
take
there
that?
are appropriate, and you will need to check, with your ADA CDT. The problem with this, if you've ever done facial pain, is you better get a fee at the beginning because it may not end. So we charge basically, many of these TMD patients is only one session, but it depends on the TMD case. I mean, if you've got really restricted movement and major oral facial pain, it may take 2 or 3 sessions for that, but you also want to add the moist heat, possibly Flexeril, at least the NSAIDs, the nonsteroidals. But many of us will charge around $150 to $200 for the session, and the follow-up session would be within that $150 to $200.
Thank you, Dr. Lau. I'm going to ask all the people that have raised their hands if they would like to talk. And let's just do a first come, first serve. Hello, Andrew Kim. You are live on air. Would you like to ask your question? We'll take that as a no. Apologies. David, how about we go to some questions that have been asked in the Q&A portion, and I'll try to set some up while we wait.
Hey, David, do you mind if Valerie elaborates just a minute on that TMD? Because she was part of a big deal in getting a code for that. Valerie, did you want to say something quickly on that?
You know, I was just going to make the same kind of suggestion that Dr. Lau
Oh,
did
okay.
with the treatment and how my doctor does it. She does it incorporating into her treatments as well. They did, you know, in 2019, they did help classify the code, the D9130 code as a potential. It is a billable code that's through the CDT, the ADA CDT. Now that you can include that therapy under that code. So that's the code that you're talking about, Paula. So that would be a good resource for offices that are looking to do a billable with, of course, a narrative on how they did that physical type of a therapy for the TMD.
Thank you.
Excellent, thank you. So we are in the last 5 minutes. I think we'll have time for a question or two more, and then I'll take those last couple of minutes to wrap up about CE and follow up, et cetera. So it's been a really quick hour. I could listen to you guys for a lot longer, but it is Friday evening or Friday night in some places, and we want to be respectful of everyone's time. Dr. Lau, this is probably a little bit closer to you. There's quite a few questions, obviously with COVID being, you know, such a top of mind situation, Christine talking about disruption already, etc. Dr. Lau, the question is about proper PPE and any changes that you anticipate in PPE because of this notion of the virus, et cetera, et cetera. Any thoughts that you can add to, you know, the personal protective equipment and things that people should be thinking about?
Again, as I suggested, I would go, no one does it better, although I'm getting like 500 emails a day that think they can. I would go to 88.org. They have they have flowcharts that are wonderful. They have from the beginning to the end. And again, the reason I would start looking at that is that even though it's for emergency situations, I think about 80% of that at minimum is going to be translatable to what we do when we come back. The type of mask we use, as far as air filtration goes, that's going to be a big one. Taking probably someone's temperature before they walk in the door. You probably, even now, most of my colleagues are actually taking the temperature when they're out in the hall before you even let them in the treatment room. This is an area in transition. It's changing every day, but I still believe going to 88.org. And if you look under the COVID, you will see excellent 1, 2, 3, 4, 5 of what we're doing now. And I think that is exactly what we're going to see in the future. There is, you know, we just don't know, high-speed handpieces, ultrasonics. But again, I hope that the pre-rinse will be one of the major areas that's going to be preventive so that we can continue to do what we do. The expense and the inconvenience, I don't mean inconvenience because of someone's life, I mean just inconvenience trying to do what we need to be doing. Because I went through the last OSHA in 91, 92, 93. But just hang on, but I go to ADA is my source.
Thank you, Dr. Lau. This is more for the hygienists on the panel. Maybe it's the last question. Several questions coming in from around the country talking about, you know, when will my state get more progressive and allow laser therapy? You know, when are these changes happening? Who's advocating for us? You know, Valerie in particular, because I've known you quite a long while and been very fortunate to do so. I know you're a strident advocate for the profession that you hold that hygiene banner very, very high. You know, what is maybe some thoughts, and then I'll go to Christine. What are some thoughts from you, Valerie, about, you know, this notion of change and how do states become more progressive, because there is such a wide variety, right, in terms of allowable procedures. You know, what would you say kind of briefly about, you know, where we are in that process and what's on the horizon?
So great question. And, you know, obviously each state is going to vary. If you go to ADHA.org and they have a great flow chart as well that that shows the delegable duties of hygienists based on state and what that scope of practice looks like. So they are our advocates for us, but even at your state level, really get involved at your state level. And again, I can only speak for the US, but getting involved with your state level and your obviously your national level, that's going to help do that. We've got some other great champions out there, I should say, too. The CMC, which is the Coding Maintenance Committee, that gets together at ADA once a year. Patty DeGanji's great. She runs a dental codiology group that I'm a part of, that we spend a whole year bringing in hygienists on a conference call once a month. And these hygienists just kind of hash out what the issues are that's going on in the nation, and how we can help support the profession. So just get involved in your profession. I think that's the main thing, is get involved, find out if you need to start somewhere, start at your state level, your local level, and definitely get involved.